Thank you so much, Rupert. It's a really thrilling for me to be able to have contributed to the published evidence base here in ketamine after so many years. So I am currently now with Osmind, Vice President Medical Affairs, and Osmind. At Osmind, we make an electronic health record that is specially designed to capture outcomes data for mental health patients. And so this is our first presentation to the world of what we can do. It is a sketch of outcomes. We are going to be fleshing it out with papers, additional papers to follow. But let's start with what we've got today. So, okay, so let me just find the click. Yeah. So let me just define, I know everyone knows, but so defining ketamine infusion therapy, which is intravenous administration of ketamine over the course of 40 to 50 minutes for depression, beginning at a dose of 0.5 milligrams per kilogram. The first RCT of KIT was by Berman and colleagues in 2000. And since then, there's been many, there's been several RCTs that have shown that KIT is rapid and effective treatment for depression. However, single doses do not last long. So they peak about 24 hours and 90% of people relapse within 2 weeks. So we are defining, so several studies, so those were single infusions, and then people began to look and see, well, if you give multiple infusions in a row in kind of like induction, does that prolong the effect? And so beginning with Singh et al. In 2016, several studies of 4 to 6 infusions over the course of 2 to 4 weeks suggested that, these multiple infusions could yield a more durable response. But really that had not been extensively studied. And so this is, so we call this an induction, and that's again 4 to 6 infusions over 2 to 4 weeks. So in 2020, Sakurai and colleagues from Mass General reported long-term outcomes for KIT induction and maintenance in 85 patients at Mass General. And here we expand upon this effort by presenting outcomes on an initial group of 9,000 patients, de-identified real-world depressed outpatients, who received KIT between 2016 to 2020 at one of 178 independent community ketamine practices. Okay. So how did we do this? So the initial data set was 9,323 patients who received KIT. This was the mood monitor data set. This is not data from the Osmind electronic health record, and this is a data set that we acquired. The clinics in the study were chosen because they were using the mood monitor measurement-based care software platform. And the primary measure utilized in this platform was the PHQ-9, which has a 2-week recall period. So it's really only valid every 2 weeks. And so providers used a web-based interface to give the report measures and to receive them in return. Okay, so we already discussed the induction phase. So from our initial funnel of 9,000 patients, we had to exclude who were entered into the system. We had to exclude 3,500 because they didn't have an induction infusion. Then we had to exclude an additional number of patients because they did not have one, they only had one induction infusion. Then 4,000 received, or 4,600 received up to 8 induction infusions within the 2 to 4 week period. And then that continued to filter down to 3,500 receiving 4 to 8 induction infusions in 7 to 28 days. And then to 1,000. So we had to have a PHQ-9 pre-induction and within 1 month prior to treatment, in other words, and within 14 to 31 days post. And so when it came down to it, final sample of patients who had a PHQ-9 within 28 days of pre-treatment and within 14 to 31 days post-induction. This is the sample that we're analyzing from the 9,000. So the majority, this is kind of, just of interest, this is an observation. The majority of people in the US are giving 6 infusions of ketamine. That was pretty clear. And most people complete their induction in fewer than 14 days. So this is happening in a pretty tight interval. Okay, so this is the distribution of baseline PHQ-9 scores before induction. And so that was a score of 18. And for people who are not familiar with PHQ-9, 0 to 4 is no symptoms, 5 to 9 is maybe mild depression, 10 to 14 is moderate depression, 15 to 19 is moderate severe, and 20 to 27 is severe depression. So this is moderately severe illness. And the mean post-induction PHQ-9 score for everyone that underwent an induction was 9. So here we have a drop in the PHQ-9 score for the N equals 537 cohort. So we had a mean raw drop in score of 8.7. Cohen's effect size was D, it was 1.5. Response rate overall defined as a greater than or equal to 50% reduction in PHQ-9 was 54%. The mean percent drop was 47%, and the median percent drop was 52%. So the remission rate, about 30%. Now, 8.4% of patients, or 8%, had a PHQ-9 score that increased. And the previous study by Sakurai, they also noticed pretty much comparable number of patients that actually did worsen. So this is, kind of the first solid data we have. All the rest of the data is always looked at whether or not it succeeds, and nobody's really looked at, the other side, right? So this is definitely of interest to us to follow up on. Okay, so I already discussed. Oh yeah, this is just the distribution. And, it was reassuring to me that the majority of people had, moderately severe to severe depression that were getting this treatment. There was a, substantial fraction that had no or none or mild depression. And then, the rest were just moderate. I will say that when I was, in private practice myself, there were people that would come in and that really wanted this for an enhancement of wellness. I think that there are some people that actually, that pursue ketamine therapy for that. So this is the baseline PHQ-9 scores for the 155 remitters. So their baseline was about 16, and for the remitters, and the likelihood of remission for each level of baseline depression was, 60% in the least severe group, followed by 44 down to 30 and then to 17. So there was, although there was no difference in response rate based on baseline PHQ-9 severity, more severe illness was weakly inversely correlated with the likelihood of remission. And that's sort of what we see with traditional agents, I think. Okay, so looking at the changes in PHQ-9 for the 4 baseline levels of depression, on the left, we have sort of mild on the bottom there, as you might imagine, and moderate, severe, and severe. And as you can see, the response rates were really the same for all those different levels. And then, so on the right, we have baseline severity correlates with drop in PHQ-9 score. And that is that there's a greater yeah, so, and there's a greater, you see a greater change in patients with more severe illness. And again, we have that weak inverse correlation with the likelihood of remission. Okay, so there were the patients that worsened. So 9 patients experienced a score increase of greater than or equal to 5 points on the PHQ-9. And that's 9 of 537. And for these 9 patients, the largest score increases were from 2 patients who changed from 19 to 27 and 16 to 24. So that's definitely concerning. And it's interesting that they hung on till the end of the induction. And 6 patients who were in the non-mild depressions, that was like 9 or less, actually increased to an average of 12.6. So, I think this does kind of need to be reflected in consents going forward as we learn to understand more about it, that there is a possibility of getting worse, even if, it's not that high. Okay, suicide. 60% of the patients had baseline suicidal ideation to some degree, and 73% of those who had that baseline SI reported an improvement after KIT. So 43%, no SI at all. And the improvement was seen for all levels of baseline severity. So it wasn't just seen, for example, in the most severe patients. It was really across all the levels. So 31% of the patients who worsened in terms of global depression also reported an increase in SI. And 5% of patients who completed the induction reported an increase in SI. Okay, again, it's so pointing to the fact that there are can be some potential negative consequences. So this was sort of interesting. It's in the supplementary data because we didn't set out to look at this. We couldn't look at this because a PHQ-9 sampling frame is 2 weeks. So, and all these infusions are happening within 2 weeks. So that's a big caveat here. But I just do put it to note that, so we do see sort of an increase of response rates as you head towards the penultimate infusions there. And interestingly, it's pretty strong at 2 and 3 even. But, then there were the people who there were some people who had 7 or 8 infusions, as we, define the induction as between 4 to 8. And, those patients had sort of a lower level of response at infusion 7 and 8. And, we sort of, again, we would need to do something we would need, to use a rating instrument that would be able to accurately assess mood changes over the course of a day or a couple of days in order to look at this more frequently. But we wondered, were these people just people like, do providers commonly try to push patients who aren't doing well to get additional infusions in order to try to get a response? Or, we just want to kind of understand more about this in subsequent paper. Okay, so now we'll go on to our Kaplan-Meier analysis, to look at the durability of response. And I have to say, I was somewhat surprised by this data. The data is what it is. So this figure shows the probability of loss of response for patients who responded to induction and have yet to receive maintenance infusions. And an event represents, so a censored event represents a patient losing response or entering maintenance. And so those patients are, would be taken out of the response calculation. So either you go into maintenance or you do not submit a PHQ-9. So we showed that the probability of retaining responder status at 28 days, and so that's 28 days after the final induction infusion, was 80%. And in my experience, I was used to sort of patients really needing a booster at about that time period. So anyway, this is the larger world and the experience at many other clinics. And the probability at 56 days was 60%. So even without retaining response, even without maintenance infusions. Okay, and then looking at sort of maintenance strategies. So on the left, we have the distribution of the time length between the final induction infusion and the first maintenance infusion for the roughly 2,000 patients who completed induction and entered maintenance. And again, this number is bigger because, there was a lot of people who we had maybe PHQ-9s after they started treatment, but not before. So that N equals 537 was having, PHQ-9s before and after. So majority of these patients who completed induction entered maintenance. So, and we'll discuss a little bit of comparison with the Sakurai study in a moment. And on average, as with the Sakurai study, patients who completed induction received only 2.6 maintenance infusions. So relatively brief treatment. And for all responders, the mean interval between the induction and the first maintenance infusion was about 46 days, and the median was 28. And that's, I think, along the lines of what what myself would tend to observe, 28 days. And for remitters, perhaps not surprisingly, the mean was 84 days and the median was 48, so a lot longer. Okay, so kind of get to some interesting comparisons here. So the Sakurai study, the response rate was, less than 20%. And despite that, the transition to maintenance phase, the number of percent of people who did that was 74%. And so they had some, roughly similar findings of a reduction of suicidal ideation. So the Sakurai study used the QIDS, and importantly, they reported their outcome, their final outcome, after just 5 infusions. So, one reason for this kind of drastic difference in response rates in these community samples, which should be otherwise quite similar, might be that the 6th infusion really does add a lot. There could be something about the severity of patient illness. These are our study is pooled data across multiple clinics, and the Sakurai study is just within their one clinic. There might be other demographic and confounding variables. And then one kind of really intriguing thing is that all of the Sakurai infusions were done between 5 and 8 p.m. And that's because that's when they had room in the clinic to give them. And, I wonder if there is some circadian effect at play there, because the majority of infusions, the clinics that we logged were in the daytime. Just something to think about. Okay, and how does our study compare with the academic studies? So we have 54% and 30% roughly. So Phillips had in an N of 39 and 60% response rate after repeated infusions. Singh and I should have put that at the top because, they're getting the highest response rate. And which, response rates do kind of tend to drift down over time. But you see it's, roughly comparable. So starting to maybe feel somewhat comfortable with this idea of maybe 50% response and, perhaps 30% remission. Okay, limitations. This is a big section. So we report outcomes on a fraction of the total sample due to missing mood survey data. And that's of note as well. So only 15% of the people that were, entered into this database had pre and post treatment assessments. And maybe we can talk about that as a group. I feel like, both patients and providers perhaps have survey fatigue, and perhaps there's not really an understanding of just how valuable this data could be, or there weren't options to contribute your data to larger scale data sets. So we can discuss that. I think it's really interesting. So we didn't have demographic information. We didn't have medical history. We didn't have substance use data. We didn't have medications. I mean, we only had outcomes. Okay. And we didn't know whether or not these people were treatment naive. We didn't know who was in therapy and who was not. So critical. No dosing. There's a selection bias about affordability. Okay, so there were more. You might ask questions about, well, did you did you sort of induce bias in the data set by by the way in which you funneled people through to get to your final sample? So we asked, well, one thing we thought was perhaps people who did not fill out surveys diligently, we had to drop them because of missing data. So what about those people? Are those people in some way different? Where they have, biased the sample in a certain way? And so we looked at the mean PHQ-9 score 14 to 31 days after induction for the 379 patients who received 6 infusions, and segmented these by the number of PHQ-9 questionnaires reported by the patients. Okay, so what we've got there is the mean PHQ-9 on the vertical axis, and on the horizontal axis, we've got the number of surveys reported. And there was no statistical relationship between the mean PHQ-9 score and the number of surveys reported. So it wasn't like the people who reported more surveys had a different outcome. So they were very motivated because they were feeling better than other people. Okay, so then what about people who drop out before the 4th infusion? Could they be qualitatively different in terms of response from those who completed? So on the left, we have the distribution of all available baseline PHQ-9 scores for individuals who stopped receiving infusions before completing the induction. So the mean was, 16. So this is a bit busy over here. I apologize for that. So the mean was about 16, and the median was 16.5. So the N equals 537 induction cohort had a mean baseline of 18. So there is a slight difference between the 16 and the 18, and which we acknowledge, but that's very slight, and it didn't put patients into a different, they're still in the moderately severe illness category. So people who dropped out and people who stayed in, their baseline PHQ-9s were, essentially the same, we argue. Okay, so takeaways, overall response, 54%, remission, 30%, response rate not influenced by baseline severity. However, and that can be encouraging to patients who might say, well, their illness is so severe, they'll be less likely to respond. That's not true. However, they may be less likely to remit. And we had this 8% of patients worsening and sometimes changing in illness category, so actually getting much worse. And overall, 5% had an increase of SI after induction. So regarding response, according to this data set, KIT is robust and 80% probability of sustaining response at 4 weeks and 60% at 8 weeks, even without maintenance. And I think it's really interesting to me that most people, well, it probably has to do with economics in large part, but people just have about 2 to 3 maintenance infusions after, and people are out of treatment by 3 months or so. Okay, and finally, because I want to get to questions. So right now we are working on our second outcomes paper with demographics, diagnoses, and we don't have, we do have some dosing data. I have to modify that slide. And some longitudinal data, and we want to look at who worsens why. We'll have, a couple of, we're going to have primary and secondary diagnoses as well. And this is a large data set, around 2,000. And then the third paper is going to have everything. So we'll use our, we've logged about 900,000 outcomes in our system as of this time, and we'll be including lots of clinical history and other, as much as we can for a real definitive assessment of outcomes. Okay, so I'm going to stop sharing and questions. See. Oh.
Thanks very much indeed. That's really an extraordinary achievement. Well done. I mean, that's amazing to have so much real world data. So let's get straight to it. Who's got some questions? Tiago, never backwards on coming forwards. That's great. Thank you, Tiago. Can you tell us more about the time point of how the PHQ-9 was collected? Was it before or after the infusions? Did the provider teach the patient to think about, teach the patient to think about the last 14 days every time, or just from the last infusion to the next infusion? So,
yeah, so I doubt it. I think, like, when I think about what, I interact with providers and all that, people are extremely busy in terms of reflecting on the last 2 weeks. And I think it's very hard for a patient to make a distinction when, that's why the recall period is 2 weeks. You're not supposed to give it in shorter intervals. And so we couldn't sort of not look at data. We had to take every data point that was within this. We couldn't select, we're only going to take like this PHQ-9 and not that one. So we took everything, and we just have a caveat that, the repeated PHQ-9s within that interval are, who knows what that data means. Our response data is 14 to 31 days. 28 days prior, anytime 28 days prior that's going to be your baseline. And then 14 to 31 days after your final infusion that's the results for the response, the PHQ-9. And that's, that's far. I mean, most people, as I said, most people are making their assessment on the 5th infusion after, but just before the 5th infusion, because then they might lose the patient to follow up, or just after the 6th. And there's probably something that happens, like, in that next couple of weeks. And it's something certainly to be looked at more rigorously. Is there a sort of a development of the response? I think a lot of us in the field would probably think that there is, like when people start to feel more energy and initiative and engage in the world, they're likely to start feeling better. So it may be that, that our sampling period, 14 to 31 days afterwards, allowed for that, but we don't know. That's something we'll look at.
Thank you. Thank you for the focus on the non-responders and those who get worse. Do you have any thoughts about potential mechanisms, for example, the nature of the experience perhaps, or correlation to comorbid personality disorder or anxiety? So this is for the patients who get worse. Do you want to say something?
Right. Yeah. So, I mean, Alison had that paper that looked at the anxious dysphoric response to ketamine, and those people didn't do as well. And I think that's probably right on. I think a lot of us who do this a lot would agree with that. And I've personally seen 4 case switches. So I know it's rare, and it is, but so there's all kinds of different things. And I wonder a little bit about the anxious dysphoric response, and if you followed those people, if there wouldn't be a possibility that there's an underlying bipolar diathesis. I feel like there might be, in some cases at least. So that's all I know. It happened in all the categories, the worsening. So it wasn't dependent on, it wasn't just the very worst people saying, oh God, this is never going to work for me. It was everyone.
So your data you haven't got any particular data from this paper that help us really pick out who the people are going to get worse. Huh?
Yeah, we can only say it's like, it doesn't have anything to do with suicide. It didn't have anything
because they get better.
Yeah.
Okay, that's really helpful. Thanks. Was the variability in the different centers?
Well, I don't know, because it's all pooled, and so I don't know that.
So the average number of people, I mean, presumably there was variability in the data quality and the number of people.
Yes,
who each center.
Absolutely. I mean, there probably was. I mean, there probably was. I think we can.
Because you've got 178 centers, haven't you, and 500 odd participants. So the average number per center is not very high. But right.
And it may be,
there'll be some that are much more than others.
Right. Yeah. I absolutely. That's not. Yeah. And unfortunately, I just can't speak to that.
Yeah. Okay. Thanks. Okay. And Alan Schatzberg asks, can you say something about the response in the people who received 1 to 3 treatments? How did they do on follow-up? So also in the induction folks, did the first treatments predict response? So 2 questions there. How did the people who just got 3 infusions do?
So the people who just got 3, I mean, even though again, it's hard because that's like a few days into the new PHQ-9 sampling frame. But if you sort of remember the supplementary data, which you can look at your leisure, there was like 27% of people had a response at 1 infusion. And then it was like by 3rd infusion, it was like 40. So, as to why they left, we don't know. As to what happens to those people after they left, we don't know, because they dropped out of treatment. They left. Yeah. But it's a very interesting question. And, I mean, maybe like some of the people who dropped out in the 3rd infusion were like, I feel a lot better. So why am I going to pay for this? I mean,
yeah. Okay. And did the first treatment predict the response? Just the very first one, or don't you know?
I don't think you could say that. I don't know. I'm not sure. I can't say.
Okay.
Back that.
And then Filippo Passette asks, what about the distinct items of the PHQ-9? Any particular insights from looking at those, predicting response, guessing at diagnosis, etc.?
Yeah, we could only look at item 9 just due to the sort of overwhelming nature. Yeah, and so we tried to look at that as carefully as we could. I thought it was interesting that it was a very strong response. The majority of people who had suicidal ideation no longer had it. 40% of people no longer had it at all. That's pretty good.
Last question in the 2 more questions in the Q&A before we go over. This was just an IV, wasn't it? Not all routes of administration? Or did you collect data on all?
IV. This is all IV.
All IV, yeah, okay. And Madeline Brendel asks, what about the cost component of the treatment? It would be interesting to gather data from those centres on what they typically charge patients. Was there any relationship between how much you charge and how well you do?
Oh, well, without doubt, I think there probably is. I don't know that. We didn't look at it, but I can tell you that the treatments ranged from $300 to $600.
Yeah, you said that, yeah.